Max power, max chaos. When you bring Epi to the party, you're bringing a big gun. So let's talk about it in this Vasopressor series that we're going through. Hi, my name is Leah. I've been a CVSU nurse for 18 years, and we're in the middle of a vasopressor series that we're going through some of the most common drugs that we use as vasopressors in the ICU setting. And we're talking about what receptors they activate and when we should probably use each one. Epinephrine is a powerful alpha 1, beta 1, and beta 2 agonist. And so, what that means for us is that it is going to cause an increased heart rate, an increased contractility, and it's also going to cause vasoconstriction. All of those things are going to work powerfully to increase your patient's blood pressure. Sometimes those effects are way too much, and sometimes they're exactly what we need. If you ever read a patient code, you've pushed amps of epi, but we use it in the ICU setting to titrate gently to get the patient where we need to go. We use it commonly after a patient's had open heart surgery in different facilities to increase the patient's heart rate to increase the patient's cardiac output. Epinephrine is also a great add-on pressor if you are in septic shock and you already have a patient that's maybe on Levophed already, maybe they're already on neosynephrine and they're just not cutting it, you may need to add epinephrine on. But the downside of epinephrine is that it causes tachycardia. So if your patient's already on Levophed with a heart rate of 130 because they're in septic shock and they're febrile and all the things, then epinephrine may not be your guy. You have to understand if the epinephrine is going to cause even more tachycardia, will that actually make your patient's cardiac output even worse and make the blood pressure even worse? So it's a really hard decision sometimes about adding epinephrine on, but it's something that you have to take all the things that epinephrine is going to do into account to decide if that's the right drug for you. Another downside of epinephrine is that it will increase your lactate on most of your patients. So if you send a lactate off on a septic patient and you did not have epinephrine going and it comes back slightly more elevated after you add epinephrine, it may be an effect of adding the epinephrine drip. And then lastly, and what I hate about it is that it often causes arrhythmias in patients. It's activating these beta receptors. And so because of that, it can cause a lot of arrhythmias. And so don't be surprised if you see that. Also, your patient's really sick, so they may have already going to be having arrhythmias anyway. But when you add the epinephrine, you start to see some wild tachycardia sometimes. So just know that if the last drug that you added recently was epinephrine and now you're having tachyarrhythmias that are even lethal for the patient, you may not be able to use that drug on this patient depending on what's going on. So continue to follow this series. We'll next talk about Levophed, and then we'll talk about neosynephrine, and last we'll be talking about vasopressin. And so if you're new to ICU, I would love for you to follow me here, comment, like this video. Let me know if you have any questions in the comment, and we'll keep going through all the different pressors that we use commonly in the ICU setting.